last week. So I'm going to present some of the abstracts, some of the papers, just really quickly. Sakati and his group discuss margin convergence versus SCR. I hope we can discuss a little later how much SCR is being done in India as well. Their conclusions were that the SCR is perhaps not as good a technique in their current study prospectively for massive rotator cuff tears. The outcome scores were equivalent and obviously less costly than some of these expensive allografts that are necessary. So in conclusion, if technically reparable, they advocate doing the margin convergence partial repair in their series compared to doing an SCR straight off the bat. The group out of Rothman, we can talk a little bit about pain management. I know Paul is a big advocate for pain management. I'd like to understand what's done in India. In their group, they studied Tylenol or acetaminophen as a pain control to decrease overall opioid consumption. And as a pre-med, it significantly decreased the post-op opioid consumption as well. This study I was involved in as one of the investigational device exemption centers for a prospective randomized study on the in-space balloon for the treatment of full-thickness cuff tears. You can see they're at about 25, 30 members across the United States and Canada. And they showed, and we submitted all of our data. We're over 2 years out now. We've submitted to the FDA that all the endpoints on pain, motion, and patient-reported outcomes all did well with very few, if any, complications. And this is a procedure that's very easy to do. All the endpoints had improvements, especially in pain over time, even up to 2 years. So this will be a device that in the next few years we'll be seeing. I'm sure we've seen it. Many of you may have seen it in Europe. And I'm going to end on this one, which was a long-term outcome from our colleagues in Turkey with imaging on the clinical results of medium to large tears at 10 years. So really with imaging, a great study that was published. They are hypothesized that the transosseous equivalent would provide good outcomes and high rates of healing. And you can see only about 18% had re-tears and very few had to be revised. 80% were satisfied at the 10-year mark, many of them back to sports and activities. So in their conclusions, 80% were satisfied, very good outcome scores with high healing rates on MRI at 10 years follow-up. So I think this is a great study for the literature for us to kind of discuss with our colleagues. So in the next, I think I have about 5 minutes. I wanted to go over, actually I'll finish with Ty Lee, which goes into my talk. You know, in where where Mahara is doing his studies in Korea, Japan, they have a tremendous numbers of his patients. We need to talk about, these are two different operations that are done there and here. There it's an 8mm graft. Here it's 3 to 4 millimeters, auto versus allo. So it's difficult it's almost like apples and oranges. So hopefully we can discuss that as well. But he had great success in his SCRs, utilizing his autograft technique of getting people back to work and sports. With regards to early repair, we always talk to our patients who get traumatic tears. Personally, myself, I like to treat these patients relatively soon. And Dr. Ramsey and their group at Rothman studied this. Inclusion, acute cuff tears, surgical repair within 12 months. And all of them improved if those patients were within that 4-month of injury zone, both in ASES scores and improvements in SST scores. So their conclusions were the larger and more debilitating the cuff tear that were repaired earlier, they did better. So getting it within 4 months, I like to get to it within 4 to 6 weeks, similar to the old Cofield studies. I think it's almost like a fracture. The sooner you get, the easier it is to repair and rehab them without getting into complications and stiffness. I wanted to show a couple cases of some of the newer techniques we're doing. This is a revision cuff repair. You can see relatively large. I've been using bone marrow aspirate. This is a system that allows you to take it from the humeral head. Standard transosseous technique. We use a resorbable PLA graft to reinforce on all our revisions, and we slide it down through the cannula, and then we can add the bone marrow aspirate. In a revision case, over 60 years of age, obviously multiple things that are going to decrease their healing rate. And you can see here at 2 years, we're doing imaging that shows that this patient has healed. So instead of just doing a cuff repair again, I try to do some type of augment to stimulate healing. And this patient, she's an awesome young woman, very active, unfortunately has developed Parkinson's. So part of Parkinson's is maintaining your physical therapy and your activity. She had a failed cuff repair, complete atrophy, a lag sign, tendons medial to the joint line. So in these cases where they're very active, and we'll talk with our Indian colleagues if this has made it to India and how they're doing with the lower trapezius, it's a relatively very straightforward procedure. It's an arthroscopic cuff repair on one side and then a pulver-taft weave on the other side. And once you can learn how to harvest the trapezius, it makes it a really simple, it's really about an hour case. And I think if we can teach each other these techniques, which hopefully this society will do, we can show each other what types of techniques we can use to improve our patient outcomes. And so this is just the pulver-taft portion to the Achilles with the arm in full abduction external rotation. This is her at 6 months. It was unique in that you can actually see, if you get really close, you can see the Achilles tendon graft.
Good.
Right below
you just hang
the
that
scapula.
for me as well, please?
So that's her graft on the right side. And this is her MRI at 6 months. We're following these by, you can see that very thick black line. That's the Achilles tendon graft healing. The balloon, I really hope this becomes available. It's about a 5-minute procedure. This was a randomized study. You can see pre-op and post-op the increase in the acromiohumeral interval. It really takes about 3 to 5 minutes. I mean, in Sethi's case, maybe a half hour. Vani, maybe 30 seconds. She's really talented. And it inflates. There's certain sizes, certain amount of volume you have to put in. But these are really simple to do. Very little downside, doesn't burn any bridges.
Go ahead and raise your arms up.
And this is actually this lady at about 3 weeks after surgery.
All the way down. Keep your elbows straight.
We had done nothing but done the balloon. She'd been immobilized since then.
Keep your elbows straight.
And so we had performed a biomechanical study that had shown that we can recreate the normal utilizing the balloon. So that's my talk in a nutshell. I appreciate everyone's time. We really like, or I personally like a lot of novel techniques and would love to somehow visit India and show you guys some of our new stuff from here. Thank you.